already. So today, what I'd like to do is to kind of go through 3 parts, right? The number one, caregiver profile. Some of you might have some ideas already. It's really based on the Singapore survey on informal caregiving, right? If you have read that, it was done by Angelique Chan and her team from the Duke NUS Graduate Medical School, conducted in 2010, reported in 2012, and subsequently also reported 2013 and so on. Anybody from that, Duke NUS? Nobody? All right. The second part, we'll discuss the models of care relevant to informal caregiving. Yeah, that's the second part. We'll zoom into one of those models in the US called the person and family focused care. And then the last part really is the hands-on, right? I hope if we have time to do at least 3 things. REACH 2 is a dementia multi-component intervention. ACP, or Advanced Care Planning, there is a workbook on that. I haven't uploaded that yet. I'll ask Shah to do it in the break time. And then finally, what is that? Mindfulness meditation, something that both formal and informal caregivers. That means if you're a nurse, social worker, counselor, any healthcare worker, you could do. And if you could do that, and informal carers also could do that, there is a bridge there. There is an integration that happens. So that's really the outline here. Let me just check the other questions. Oh, somebody said, leave all your regrets to the past, all the worries for the future. Okay, I suppose that's to everybody. Okay, thank you very much. Okay, great. Right, no other comments. All right, so here we go. Informal caregiver profiles. I've asked you to read. I hope you have at least kind of touched the surface of that document. It's really a summary of the informal caregiver profiles in Singapore. It is a long document. There are several sections, but I will just kind of take only some parts of it, right? The objective of that in 2010 was to find the social, economic, demographic characteristic and health profile of caregivers and caregivers. Okay, that's a mouthful. You understand what that means, right? For them, older adults refer to 75 plus, right? With at least one limitation to activity of daily living, ADL. Right, they interviewed those as well as their primary caregiver. 1,190, that's considered a big, right, sample. So in Singapore, we find that people who are recipients of care tend to be around 84, right? And they tend to be women and who have lost their husbands. Care recipients have about 5 or more ADL limitations, and about 3 IADL limitations, and about 4 chronic illnesses. Right, that's a snapshot. So, okay, there's one more here. In terms of racial or ethnic distribution, that's the distribution there. Chinese, Malay, Indian, and total. Right, we see, more Indian. That was 2010. Right, I really wonder if this distribution has evolved over the last 10 years. 2020 is the year in which we will do, or we have begun doing the census, right? Singapore census. So I wonder if we will do something like that. It is not an easy survey to do. A lot of coordination and of course money is required to achieve that kind of sample size, 1,000 over. Now we are more interested in this. Who are the caregivers? They tend to be women. Yeah, more than men. 3:2. That's 2010. And how are they related to the patient or recipient, care recipient? Daughters, sons. So the younger generation, the second generation, so to speak, right? And then you have in-laws, son-in-law, daughter-in-laws, wives, right? And the rest are not a very big portion. Husbands, and siblings, grandchildren aren't big. Marital status, most are married, 64, 65%. And then the other group, which I see to be quite a substantial and maybe a group that faces a lot of issues, are the never married. So they're the single, whether they are younger or middle age or older and so on. Those are what we call the never married ones, right? on from there. Okay. Caregivers' health. Now, that survey asked caregivers to rate their own health in various ways, right? Do you yourself have any IADL limitations, for instance? Do you yourself have any chronic illnesses? So for IADL, about 0.5. So among 2%, there might be one that have some IADL limitations, and then 1.1. So it's about 1. So about every one of them kind of has a chronic illness. So think about it. Person with chronic illness, caring for person or persons with chronic illnesses. That's the profile that we kind of have. Caregivers. Health rating. Providing care made it worse. Providing care did not affect my health. And you asked to rate. Providing care made it better. Right? So we find that many of these folks, caregivers, informal caregivers, are actually quite positive, quite optimistic, kind of do not mind, even though I have one chronic illness, that's okay. It doesn't really matter. I'm not affected. That's what we seem to see among the profile, in the profile. Next one, economic means of caregivers. Now, 55.6, that's about half, slightly more than half, are working full or part-time. And then outside of work, they take care of their patient, older, right? About 4.5 persons live together with the caregiver. That means caregiver, care recipient, and other. Maybe 2 or 3 other people live in the same house. So now you begin to have a picture that the house or the household is not just caregiver and care recipient, caregiver, care recipient, and others. So it could be siblings. So can you can now start to kind of ask yourself, what kind of impact does it make? Just having a family there, how does that impact what you call the contact with healthcare system of the patient? Right? Yes, the ideal situation is everybody chips in to help, right? That care recipient, assuming there's one care recipient, that would be ideal situation. But what happens if there is friction within the family? Right? What happens if there are other needs? Say among the 4.5 there is a baby. Right? How do families prioritize or deprioritize in order to prioritize other needs? Number of hours per week caregivers spend providing or ensuring provision. Okay, 38.1. Think about it. What is the national full-time workload hours? 44, 42 or 44? 44, right? Any HR practitioners, right? What I know is 44. So this is close to a full-time job. This was 2010. I don't know now. Right? And yes, they're not paid, exactly. Right? At least not paid for the hours they spend caring for the patient, whether it's medical escort or help to bathe or help to feed or just sit there and listen to the whatever complaints or pain and so on and so forth. No, not paid. FDWs, okay, foreign domestic workers, right? About half of these folks has the help of foreign domestic workers, right? Which is great. We have some systems now. In 2010, there weren't that many systems, financial systems and other subsidies, other support. But today we have. So I would imagine we will have a higher proportion here today. Right? We don't know yet until we collect the data. FDWs with experience, about half, so sort of half are not yet trained or not trained. Right? And okay, formal service utilization, that refers to day rehab center, dementia care center, nursing homes. Now today we have home health, home care, home nursing, home therapy, home medical, all those. Those are what we call state provided, may or may not be subsidized, subvented, what they call services. Rates of using are very low, were very low in those days, 2010. I would imagine the rates are higher now. I sat in last week, Xiang Jai's presentation. I didn't catch. If you did, you let me know. But I hadn't catch him saying anything about rates of utilization today. He would know. AIC would know. AIC would have the data, right? I was with AIC for 4.5 years. And in fact, my time there, me and I think 2 of my colleagues and I were the ones who actually pulled data out from the operational referral database. The most ancient is called the nursing home. They had a term for it, short for who? I forgot. Integrated nursing home system. ILTC, no, that's even earlier than that. There is another system where, yeah, so prior to 2012, nursing home system and then community hospitals right, were separate systems prior to those days. And then dementia, daycare, and other what do you call that? Other long-term care services, they do not even have their own proper system, not yet set up. Today, each of them are set up. They are linked in AIC, right? But of course, the fields may not kind of tally all around. In fact, by the time I left in 2015. We only know that at that point, nursing home data was clean, very clean. Clean meaning whatever information, operational information we want to obtain from the data set, they can just kind of look for the field and just. So people from outside ASE could write in to request. Right? Even Ministry of Health write in to request. Yeah, that's right. That was clean. Home care has always been challenging. Home care, you realize the services keeps growing, right? From home medical to home nursing to home therapy, then they have home health, then they have home meals, then they have, what's the newest? I have lost touch. There are now about 6 to 8. Check Xiangjai's slides. Oh, thank you. Hospital to home. Thank you very much. I see that. That's right. Oh, let me see. For slide 10, means elderly population of 5.7% is depressed. I think I haven't come to that yet, right? Depression. Oh, I see. Oh, the Indian, let me just check. Did I say the word depression or depressed? This one, huh? Is this? No. This one. All right. Yeah. Care recipients' depressive status means CSD. So this measures depression, CSD, right? So the question is, means elderly population of 5.7%. Where is that total? Yeah. So among the 1,170 surveyed, 5.7, that's right. Right. Scored beyond the cutoff of CESD that indicates depression. I hope that answers the question. Right. There is a cutoff for CESD. There are different versions of CESD. Different versions have different what we call number of items, and then therefore different cutoff points. Okay, I hope that answers. Thank you. All right. Move on to where were we? Right, you have a question?
No, I think that's a clarification. Right. The number wasn't a percentage of the sample, right? Rather, it's a score.
It's a score? Okay. That's the question. Let me just check.
From what it says here is a mean CESD score, 5.7.
Oh yes, you're right. Thank you for the clarification. Yes, I'm sorry, I beg your pardon. That's right. When it says total, it means the average of the 1,170 caregivers. Sorry, not care recipients, not caregivers. Right? The average score was 5.7. I beg your pardon. Whoever's at home asking that. That's right. Beg your pardon. Okay. So let's move on from there. Defining caregiver burden. Okay. It's a term. This term caregiver burden has been around for many years. I think more than 2 decades, perhaps more than 3 decades. Right. Today, people have used other words to kind of refer to this, like caregiver stress, caregiver role burden, caregiver task burden. Some even link burden to depression and say they're no different. Caregiver depression equals caregiver burden, right? There are others who link it to caregiver health status and say they're no different, right? So today there are also several what we call scales or inventories that measure this caregiver burden. The most well-known, or two of the most well-known are, first of all, one of this is called the Caregiver Reaction Assessment Scale. That's one of the well-known ones, right? There are many others, but this is one that has been used, that keeps on appearing in research articles. Another one is called the Zarit Burden Scale, or Zarit Burden Inventory. Z-A-R-I-T, Zarit Burden Interview, I beg your pardon, right? Zarit Burden Interview, right? That is well known as well, that measures caregiver burden, right? Right. In that survey in 2010, right, caregiver burden due to lack of family support, caregiver burden due to financial impact of caregiving, and due to impact on schedule and health, right, were as follows. The mean score among the 1,170 caregivers being, we see that a lot of them say, I feel burden due to lack of finance. Long-term care is expensive. Caregiving is expensive. Today, what we know, right, not from Singapore data, but from data elsewhere, is that these finances isn't talking about the total cost, as in the cost of the service. We are really referring to out-of-pocket costs. That's what we know from countries elsewhere, out-of-pocket costs. Yeah. Just to clarify that, impact on schedule and health. Well, schedule really refers to time, right? We said earlier on that, what, 30 something? What is the number of hours worked? 33 or something, right? 38, right? Close to a full-time job. Right, thank you. My earlier slide. That's right. So that was 2010. Today, I don't know. What's your guess? Is this number going to be higher? Are these numbers going to be higher? I don't know. So the gaps that were surfaced, I have two slides on this. First, that caregivers are predominantly female. Now, why is that a gap? Okay, so caregivers are predominantly female. Does that mean that men do not care for women? When they're old? As in when the women are old, when the spouse are old, when mother is old. So that's the gap. We don't know. That's the gap. Number two, use of foreign domestic workers to help care for frail, right? It's the predominant strategy Singaporean families use to provide care. There seems to be quite anecdotally on the ground observation as well as research kind of shown already today, right? By the number of subsidies that is taken, right? Ministry of Health. Somebody just needs to ask Ministry of Health for the statistics. I have a comment there that says, men dies younger. That's true, right? We know life expectancy is different. Is it 82, 83 for men and 87 to 89 for women in Singapore? Life expectancy at birth, right? So yes, that's possibly true, right? But is it really life expectancy, or is it they do not care, or they do other things? They get foreign domestic worker to care. That remains an empirical question to be answered by research. Right? There's another one, but Zarit has constraints in local context. Yes, absolutely. Yes, I don't have time in today's seminar. If we had time to go into those inventories, Zarit Burden Scale, CSD for depression, the Euroquote or the Quality of Life inventory, you would see that some of those items there are just what we call not culturally valid. So much so that locally we have developed our own version of the Euroquote Quality of Life scale. It is done by Lo Nan and his team. Lo Nan is now at Saw Swee Hock School of Public Health. Right. That's right. It says, I also think it's more a social role, the patriarchal society. Yes. We'll talk about that at part 2. Thank you for the contribution, you at home. I don't know who wrote that. Ben. Yes, we'll talk about that in the context of model of care. In a patriarchal society, what is the model or what kind of model of care works? Okay, so 50% of FDWs do not have experience or formal training in care. I think we said that. Why is that a gap? That is a gap simply because we need to train them, right? And obviously they had to be trained, and they had to want to be trained. The second slide on gaps. Increased caregiver depression and stress are a result of these are the findings, right? The fact that caregivers hold a full-time or part-time job already, right? That they are younger, perhaps that means not so much personal caregiving experience, or that there's several other personal responsibilities in life. Negative reactions to caregiving, right? The idea that caregiving is added workload, added burden, right? And I don't know. I'm not trained. I don't have enough information, right? So I'm not it's not fair for me to provide care because I'm not really trained for it or prepared for it. Caregiving hours, we've talked about that. Low caregiver self-esteem. Well, there are inventories to check on that, right? Think about in the family context. If you think about filial piety, right? You think that if I can't care or provide financially for my mom, for my dad, I'm not a good son. I'm not a good daughter, right? That means I'm guilty of the lack of filial piety, right? That impacts self-esteem. Low SES, we can understand that, right? Financial resources, income. Being a spouse caregiver. Now, this one, I like you to think about end of life. Losing a spouse, right, is known to be among the highest, if not the highest, stressor, right, in the lifespan of one's life, right? In psychology, the classic theory is Erikson's theory. Erik Erikson's psychosocial theory, where he kind of put a kind of rank and ask people to rank what are the various things that stresses you up. Right? So people fill up. First of all, he got people to fill up all the various things, various events, and then he got after he got kind of a stable list, no new items added to those events. Then he got another group to rank the importance. And it seems like over time, across different geographic boundaries, results tend to be consistent. Right at the top, death of spouse. Yeah. Next, presence of memory and behavioral problems. Right. Think about the various. In Singapore, we probably are quite happy when we hear during budget statements every time February, March, this many goodies will come your way. Last year, $200 monthly cash payout home caregiving grant. I don't know if those of you who rose your hand just now as caregivers, you got that or you have gotten that, right? This year, another new budget coming. But how are all these going to address memory and behavioral problems, especially for dementia patients and their caregivers? Right? We know that the burden of dementia is among the highest, if not the highest, right? On society, whether at the societal level or individually, the family. Right? How do we translate these financial subsidies, even subvention, right, to aid memory and behavioral problems? Right? We'll talk about this in the context later on. Part 3, the multi-component analysis. Multi-component intervention, reach 2. Right, we call it. The next, absence of an FDW. Wow, think about it. Increased caregiver depression and stress are a result of absence of a FDW, absence of a foreign domestic worker. What does that tell us about us, right, as caregivers? When I was when I was growing up, when I was a teenager, I never thought that a domestic maid or FDW would be hired to care for an elderly, for a senior. At that time, what I was told when I see other my friends, as in my peers, teenagers, have a maid at home, is that these maid help care for their younger brother or sister, help do the housework. Never thought that, right? So then relieves the burden of the dad and the mom and so on. Today now, when somehow we're unable, perhaps due to financial resource constraints, but perhaps due to other constraints, unable to get a foreign domestic worker, and yet we have a senior at home, that becomes a burden. Think about it, would that be a burden, an additional depression or burden source, if the person who requires care isn't a senior but a junior, like a baby, like a young kid? Would you say, would any parent say, absence of a foreign domestic worker adds to my depression as a father, adds to my stress as a mother? Think about that.
Maybe not depression, but it's stressful. I mean, I never had a maid for my children, but I think for some people who find childcare difficult, I think for some of my friends or colleagues I have, when they some of them actually find childcare very stressful, so they're very glad to have a caregiver in terms of a foreign domestic helper. Although for me, I have a very different perspective. I wanted to be in touch with them in their lives, so it's a different perspective.
Thank you for sharing. Yes. Yes, thank you. Yes, that's true. Let's see, did anybody at home say, you actually say yes? Ben says yes, actually need to work to get money to sustain daily living, and yet the cost of children is high. Right. Okay, thank you, Ben. Amy says children fall sick when in childcare. Yes, and so many parents would rather self-care for children rather than, yes, right. I just wonder, many children fall sick in childcare. Many seniors perhaps will fall sick in day rehab center, dementia care. They won't, huh? They won't, huh? Yeah, you got something to share? Go on.
Sorry, I think that I'm not a healthcare personnel, but that is because of the immunity. So when young children who have who have never had the sickness, they mix with other children, they get sick. But for the seniors, they could get sick as well. But I think for general illnesses, they already have the immunity, but of course they are frail.
Yes, true, that's true. Any other sharing? I see some. Yes, that is in fact true, right? That's in fact true. We know that from medical perspective. Yes. Thing is though, would we want our senior to be unsafe? We don't want that. I don't think, right? We would trust our senior or entrust our senior to a foreign domestic worker. We would not want to entrust our child or children or infant to a foreign domestic worker. Think about another perspective, lifespan, right? So the beginning of lifespan, infant. The end of lifespan, when one is very frail, perhaps bedridden, right? In those two extreme age groups, or lifespan groups, may not be age groups, would we want to entrust our life to a foreign domestic worker?
Right? I think some of it maybe it's also a cultural thing, because a lot of expats, they have a lot of foreign domestic workers to actually look after the infants. So they see it equally, I think, because they are getting the foreign domestic workers also for infants.
Yes, sure. Yes, thanks for sharing. Expats, you're saying in Singapore, right?
I think culturally,
okay,
where you can actually afford it, domestic workers. But I think Europeans are quite open to, while they're actually very involved in the child, but when you give them an option of actually having foreign domestic worker, a lot of them actually are open to, having, and also I think at times in India, when you have some of the helpers that you will be with you for a long time, so they also get really involved in kind of bringing up the child. So that's another way to see it actually.
Yes. Yeah. Yes. So I think the points I'm hearing kind of tell us that absence of an FDW may not actually amount to a gap. That's what I'm hearing from the class right now, as well as from people at home. It may be a gap, but it may not be a gap. It's just that in 2010, with this 1,170 caregivers, this seems to be a gap that contributed or at least somehow influenced depression and stress. Okay.